Welcome to AETCM, the emergency medicine channel. Shall I? Presenting the case of 5-year-old child who presented to ER with accidental ingestion of button battery. On PAT examination, on appearance, child was alert and active. Breathing, there was no increased work of breathing. Color of the child was normal. Coming to the primary survey.
What all things will you check in PAT triangle?
Initially, when the child comes, we look for the appearance of the baby, whether the child is anxious or alert, whether the child is active or drowsy, you can check. Then coming to the breathing, we can look for the normal breathing pattern.
So, in appearance, we need to check for tone, interact, color, look and sound or speech. That much things. Those 5 things you will have to see. Okay. Breathing?
In breathing, we have to look the pattern of the respiration, whether the child is using the accessory muscles of respiration. Then coming to the color, we can see whether the child is pallor or normal color the child is having.
And if possible, CRT also. Okay.
Coming to the primary survey on airway, patient, there is no, the airway is patent, there is no pooling of secretions. In breathing, patient had a respiratory rate of 22 with a saturation of 100% at room air. Air entry was bilaterally equal and child was not using any accessory muscles of respiration. On circulation, child had a heart rate of 93 per minute with a BP of 100/65 mmHg and capillary refill time was less than 2 seconds. The skin color was normal. On disability, patient responded well to the verbal stimulus and the child was obeying commands. On exposure temperature, the child was afebrile. The weight of the child was 18.9 kg with a height of 118 cm. Coming to the sample history, 5-year-old boy presented to the ER with complaints of accidental ingestion of button battery while playing with the toy. He presented to the ER within 1 hour of ingestion. No history of coughing, drooling of saliva, pain on swallowing or reduced oral intake. No history of vomiting, GI bleeding, abdominal pain or abdominal distension. No history of melena. On examination,
Before going to examination, is there any significance in the number of batteries the child has taken?
Yes.
What is the significance?
Because on increasing the number of batteries, on exposure to the acidity in the stomach, the contents of the battery may leak into the stomach and can cause erosion and necrosis of the tissue. So on increasing the number of batteries, the damage caused also will be more in the child.
Okay. And another thing is, this battery is, what battery it is? Is it a AA type of battery or small magnetic lithium battery? Okay. So if it is a magnetic type of a battery, what will happen is
two batteries can, due to the magnetic power, can stick together, and the bubble loop coming in between the two batteries, they will be eroding necrosis. Pressure necrosis can take place.
Okay. So if it is multiple battery ingestion, we need to admit and we might have to plan on removing the battery. Whereas if it is single battery ingestion, we can consider this as a stable child since there is no history of any other vomiting or melena. Or what all things will you ask?
Initially, we will have to ask whether there is any coughing or respiratory difficulty to know whether it is in esophagus or anything. Then we can look for the drooling of saliva. Then we can ask for whether there is any vomiting symptoms, abdominal pain, abdominal distension, whether the child is able to take the oral feeds or not. Then whether there is any history of melena, anything can be.
Okay.
Coming to the examination part, child was alert and active. On per abdomen examination, it was soft and non-tender. Bowel sounds were present. Other systems were within the normal limit. Then child was presented at 1:30 p.m. to our ER. We initially took an X-ray, abdomen erect at that time, and then we had seen a foreign body in stomach. So we had kept the child at NPO, and then
so if a child is coming with unknown ingestion, some foreign body, some piece of the toy or something, when will you plan on taking an X-ray?
First, when a child comes, we can ask the history to know what he has ingested. If we know some metallic substance or radio opaque substance has been taken, then we can go for a X-ray abdomen erect.
Abdomen and chest also.
Correct, we can take. So in the if the parent complains that multiple battery injections are there or magnetic injections are there, immediately we go for the X-ray and then plan for an endoscopy to remove the foreign body.
Okay, so suppose they have taken the child has taken some plastic piece of a toy. When will you plan on taking an X-ray? It is not radiopaque. So only if the child is having some sort of any respiratory distress. If what will happen if that child has aspirated the foreign body? Where will it go?
It will go into stomach.
No, it can go to stomach also.
Yes.
Trachea also, mostly in the right bronchus. So sometimes those, very rarely only we will get this history. Sometimes the child can come after 2-3 days with complaints of fever, cough, breathing difficulty and all. They might have aspirated this thing and that might have caused an infection. So when you check the X-ray, we will see a collapse of the right lung. Okay, so if at all the child is coming with such a history, always check for the airway. If it is not seen in the airway, look the breathing pattern and air entry. And if at all you are feeling that it is went into the airway, take a chest X-ray and see. So only if it is not metallic, if it is metallic, definitely we can see. Non-metallic cases depending on the patient's symptoms. Okay.
So here we have taken an X-ray, abdomen erect, and then we had seen that the foreign body.
Ideally, we need to take both X-ray, chest and also abdomen, because we don't know where it is. What is the significance of it being into the esophagus? What will happen?
In esophagus, more damage can be caused. Within 2 hours of ingestion, they can lead to the necrosis of the esophageal tissues. So it can lead into the stricture formation, and then patient will be not able to consume the food, and patient will have difficulty.
And it can cause tracheoesophageal fistula and even aortoesophageal fistulas also it can cause if it is eroding. So it happens after 2 hours anyway it will happen. So within 2 hours, maximum 12 hours we need to remove that. Okay. What is the significance with the size of the battery?
In the size more than 6 millimeter, more than 12 millimeter, we have to remove the foreign body as fast as possible. If it is less than that, and if the child is more than 6 years of age, then we can wait if it is in the stomach or in the intestines.
Okay. And another thing is that if it is in the if it is a big battery, if it is more than 2 centimeter in diameter and more than 5 centimeter, it might not pass through the gastroesophageal junction. It will get stuck there and it will erode the esophagus. Okay, so in such cases we need to remove it fast. Okay, so first we will take a at presentation X-ray of the chest and also abdomen. Then so you, where did you see the this thing battery?
The foreign body was in the stomach of the child.
In the abdomen. Okay. Then what will you do next?
Then we had planned for the OGD-scopy in order to remove the button battery.
Before OGD-scopy, do you have to take another X-ray?
If there are multiple batteries and we are only seeing one battery in the first, that is erect X-ray, then we can go for the lateral X-ray also.
Even in single battery also, even though we are only seeing one battery, we need to take a lateral X-ray. Why we are taking lateral X-ray?
To know whether there is multiple batteries or it can come one behind the other in the APV, erect view.
And another thing is that we need to see where exactly it is. So lateral is to see the anatomical location of the battery. If it is just in front of the vertebra, that means it might be mostly retroperitoneal. So retroperitoneal, which is a retroperitoneal organ in the GIT? Second part of the duodenum. So if it is just in front of the vertebra, we can tell that it is in the duodenum. If it is anterior to that, we can tell it is sometimes it can be in the stomach or in the intestine. So depending on the anatomical location, and depending on the how close it is towards the vertebra, we can tell where exactly it is. And with progression also we can say accordingly, because in the stomach and in the if it is in the initial X-ray, if you are seeing the stomach, and later on if you are seeing it in the transverse column, we might not understand where it is. We will think it is still in the stomach. So based on the lateral X-ray, we can find out whether it has progressed or not. Okay. So so immediate first itself chest X-ray and abdomen X-ray to find where it is. Then if it is in the abdomen, we will have to take a lateral X-ray also. Okay.
Lateral X-ray also was taken in this child, and then we had planned for an emergency OGD to remove the foreign body from the child.
So this was in the stomach only. Okay.
So then by the time we had cleared the PAC and then gone for the procedure.
So what will happen if we allow it to be in the stomach?
In the stomach being there, three things can happen. One is due to the acidic content, the contents of the battery can leak into the stomach and cause necrosis of the tissue. Otherwise, due to the electrical charge of the battery, from the negative pole an electric current can pass to the tissues, that also can cause the necrosis of the tissue.
Okay. Which side of the battery is dangerous? The negative
pole.
Negative side is more necrotic. So when you are seeing a button battery, there will be a wide side and also a small side. So the small side is the negative side, and the negative is more narrow and it is more necrotic. Okay.
Here in the second time when we repeated the X-ray, the foreign body was passed from the stomach into the small bowel loops. So we had withhold the OGD scopy that time, and then we waited so that to see whether the foreign body gets passed out. So again after 2 to 3 hours, again repeated X-ray was taken. Again the foreign body was found to be moving down to the ileocecal valve, and then after that a patient was monitored for the 24 hours in the ward, and the next day when repeat X-ray was taken, there was no foreign body in the X-ray, and then the bystanders told that the foreign body had passed out through the motion.
Okay. So what will you do in the ER? So if suppose such a patient comes in the future, how will you assess and how will you plan?
Initially, if anybody comes with a history of a witnessed intake of the battery or any magnets, then we have to, if it is a magnet, we have to urgently go for the chest X-ray and the abdominal X-ray, both AP and the lateral, and the other, and then plan for the OGD scopy. That is, we get in touch with the pediatric surgery, gastrosurgery team, and then go for the OGD scopy in order to remove.
If it is in the esophagus or stomach.
If it is not, if the child is showing the symptoms also, we can plan for the emergency OGD scopy. Symptoms like otherwise multiple magnets also, we can go for the OGD scopy. If the child is asymptomatic,
of patient should, if at all the patient is showing any symptom, if the patient came after 2 hours and we are seeing if it is still in the esophagus or gastroesophageal junction, then we will have to plan on an emergency OGD scopy. Then what symptoms of any intestinal obstruction, we will have to plan on emergency OGD scopy. Or if it is multiple magnets. So these 3 conditions we will have to plan on emergency OGD scopy. Either in the esophagus more than 2 hours, or if it is multiple magnet, and if it is any features of intestinal obstruction. If not,
then we look for the discharge criteria. There is one criteria that if it is a single magnet ingestion, if it was an accidental ingestion, if the child is not having any comorbidities, if the child is tolerating oral intake, and the child has presented within the 24 hours of ingestion, and if there is a caregiver who can provide close observation, if all these criteria are met, then we can give the child an advice leaflet and then discharge the child.
Why they have given the option of accidental ingestion? That is, if that means if we are suspecting any non-accidental injuries, that means if we are suspecting somebody has given it purposefully, then we are not supposed to discharge. If we are very sure it is accidental only, we can discharge. Okay.
And then for the giving an advice leaflet, we should convey to the bystanders that within 6 to 12 hours, if any symptoms appear, they have to immediately report to the ER, and otherwise they can wait up to 1 week of time for any symptoms to appear. If there is no symptoms also, then after 1 week they can come for a re-X-ray and then check.
So ideally, ideally we are discharging them only for 6 hours. Ideally, we will tell that you come after 6 hours. We will ask, or in our these are UK guidelines. There they will discharge. Here we can make them wait. in the ED, we can make them wait. So if the patient is not having, what all things you told, discharge criteria,
single magnet insertion, accidental ingestion, there is no comorbidities, tolerating the oral intake, presence within 24 hours of ingestion, and the caretaker can provide close observation.
In such scenarios, we can ask them to either discharge, or we can ask them to come after 6 hours. Within 6 hours, if the patient develop any difficulties, they can immediately come immediately. Otherwise, if they are not having any symptoms, ask them to come within 6 to 12 hours to repeat an X-ray. Then in that repeat X-ray, we will check for the progression. If it has not progressed, then we will have to again consider admitting and calling the endoscopy team. If the child is having a progressed this thing, only we can ask them to come after 1 week. So anyway, an X-ray after 6 to 12 hours is mandatory, a repeat X-ray. If it is progressing only, we will ask them to review after 1 week if there are no symptoms. Okay. Anything else? What are the other type of batteries?
Mainly 2 type of batteries we get, that is the lead content battery and the mercury content battery. Then based on the contents of the battery, based on the size of the battery, we can classify it. Basically, there will be a letter coding for each batteries, and those letters represent what is the content of the battery. For example, if L is written, it denotes manganese dioxide, S means silver oxide, like that letter coding will be there. And also to know the diameter of the battery, also there will be some coding. If it is a 4-number coding, first 2 numbers will denote the diameter, and the last 2 numbers will be denoting the height of the battery. And similarly, knowing the device also, we can make out what is the content. For example, in the watches, toy things, everything, it will be mainly having silver oxide, mercury oxide, manganese oxide things.
Okay. Is there any significance with the by ingesting a new battery or old battery? Any difference?
The charge of the battery will be different. If it is a new battery, the electric current from the negative pole will be more, causing more damage to the child.
But the heavy metals in both the batteries will be same. So electrical charge induced injury might be less if we are using an old battery, but all the heavy metal induced changes will be the same only. Okay. Anything else? Depending on the size?
Depending on the size, if it is more than 12 millimeter, then we have to immediately remove. If it can get stuck in the esophagus, so
especially in children
less than 6 years of age, it can get lodged in the esophagus, so we have to remove that. If it is less than 12 millimeter and if the child is more than 6 years of age, then we can wait for the passage of the button batteries.
Okay. Anything else? So this patient, what happened? Passed stools and it
got emptied,
removed by itself. Okay. Anything else? Okay. Thank you.